Okay, so now we're going to do our assessment lab, and if you haven't already, on Blackboard you have your handout, and this is what you're going to need to fill out as we go through this lab, because the numbers and the values that you need to make a few of your calculations in here are going to be graded. So have that with you. Go get that if you don't have it. So let's start with station number 1, the sensory assessment. So what we're going to start with is sharp and dull. Easy thing to use, readily available, is just a paper clip. So I'll come to the patient and we'll go to each of those areas. Let's start with the plantar foot on the right, and I'm just going to ask the patient, I want you to tell me whether what you feel is sharp or dull. So I like to understand what is sharp and what is dull. So this is dull and this is sharp, okay? So I want you to close your eyes, don't look. And you know, here's the thing, your patients want to get it right and they're going to peek. So you need to explain to them, look, this is not a pass-fail test. You just need to be honest with me with what you're feeling. Okay, so let's start with the plantar foot on the right. Sometimes I'll pick a few different areas. Is that sharp or dull?
Dull.
Okay, how about now?
Dull.
How about now?
Dull.
How about now?
Sharp.
Okay, all right, so sharp or dull, and that's plantar surface. If we do the dorsal part of the foot, you may pick a few different areas. So again, sharp or dull?
Dull.
Okay, sharp or dull?
Sharp.
Okay, sharp or dull?
Dull.
Okay, all right, and obviously this person has a few deficits because she had a couple of them wrong, but I told her to give me some wrong answers here. Okay, so light touch. You can use a cotton ball if you want, again, something readily available, and you're just gonna ask them, let me know if you feel this. So again, we may pick a few different spots on the foot. Okay, do you feel me touching you?
Yes.
Okay, where?
On the ball of my foot.
Okay, how about now, am I touching you?
Yes.
How about now, am I touching you?
No.
Okay, and how about now, am I touching you?
Oh, I think you lightly are.
Okay, where?
The outside of the bottom of my foot.
Okay, and how about now?
Yes. On
Where?
the top of my foot.
Okay, so there's light touch with the cotton ball. Okay, if we want to do vibration, use your vibration and use your tip here. And again, let's pick the IP of actually the distal phalanx on the right, and we'll also pick the medial malleolus. So again, let's go on the right foot here. You can go. Feel anything? Okay, what do you feel?
Little cold pressure.
Okay, do you feel any vibration? How about now?
No vibration. Just I feel it.
Okay, so you're noting if they sense the vibration across the malleolus. We could come over and over here.
I feel the vibration there.
Okay. All right, so there's vibration, and then proprioception. So again, I'm going to ask you, let's open your eyes for a minute. So this is up and this is down. Okay, and this is up and this is down.
Okay.
So I want you to close your eyes, and I want you to tell me, is your toe, is it up or down?
It's down.
Okay, so this is proprioception. And again, is your toe up or down?
Up.
Okay. Is your toe up or down?
Up.
Okay. Now let's look at your ankle. Is your ankle up or down?
Down.
Okay. Up or down?
Down.
And up or down?
Up.
Okay, good. So there's proprioception. All right, so if we go to deep tendon reflex. So primary deep tendon reflex of the lower extremity, we can do Achilles and patellar. Let's do Achilles for here. Sometimes I don't have my reflex hammer. I just relax, okay? And a lot of times if you hit it just right, you can get it with your hand anyway. She's getting a good reflex just with me hitting her there. But again, reflex hammer, you get right on the Achilles, you give it a good tap, and that's a good normal 2+ there. We can try the other foot, just relax. She got more readily on that one. Let's do the right one. There we go. So I would say on this person, we have a little bit more of a reflex on the left than the right, but both were pretty normal. Okay, so then lastly, the monofilament testing. If you recall, 5.07 is the one that you want. That's the threshold for. Beyond that, there's definitely more sensory deficits with the diabetic, and pretty much everyone should have this sensation. As we get older, we may lose a little bit of it, especially you want to be careful if there's a lot of calloused or dead tissue in the area. That's not really fair because they don't really have, you want to have a good viable area. So again, your monofilament testing, here's 5.07. And I want you to turn to page 2 on your sheet. Now we're looking at the diabetic foot screen, and we're going to go to 4 specific areas on the foot. Now, at the hospital where I work at, we ordered several of these because they're disposable. You don't really want to reuse these on people. And it came with a recording sheet, and there was actually 10 areas. So depending on what you've got, you may or may not want to test more areas. It kind of depends on what's going on with the patient. Most of the time you're going to see that they don't have great sensation on any of them, but to test various aspects of the foot is going to be crucial, okay? So I want you basically to let me know if I'm touching you or not. So I'm going to touch some specific areas, and I may not be touching you. So again, just be honest with what you feel. If you don't feel anything, say okay. All right, so first of all, am I touching you?
Yep.
Where?
Toe, big toe.
Okay. And am I touching you?
No.
Okay. How about now?
No.
Okay. How about now?
Yes.
How about now?
No.
Okay. And how about now?
No.
So I just did another one on the heel. So where she said yes and where she said no, you'd want to make note of that. You want to make sure you touch enough that you bend the filament. You don't want to touch and still have it straight. Give it a little bit of a bend to it so that you give adequate pressure, okay? I like to do also dorsally, and sometimes I've actually worked up the leg because you'd be surprised. Sometimes that sensory deficit actually extends higher on up with people who have more advanced neuropathies present. And you can only imagine if they don't feel any of that, it's probably the equivalent of walking, if you've ever had your foot go to sleep, how hard it is to walk and not feel the ground. And that's so many aspects of what we have to think about for that patient. Making sure that they check their feet every day, but even more so for balance. How much is that person affected by walking on surfaces that may not be level, that they can't sense? So definitely checking that, especially with patients with wounds, and you want to check both sides, because we're not just into trying to heal the wound that's present, but we're into preventative medicine. We need to look at that other foot and see if there's something brewing over there that we might need to talk to the patient about and educate them to keep them from getting a wound on that side, okay? Okay, so second lab, station 2, we're gonna look at vascular assessments. So moving on down on your paper, we're gonna start with palpating pulses. So the best place to get the popliteal pulse is with the patient in prone. If your patient can't lie prone, obviously you're gonna have to modify, but here's a good subject here in prone. So you want to palpate using 2 fingers, come just lateral to the medial hamstring tendon, and apply a little bit of pressure here. And you want to make sure you don't push too hard or you're going to occlude the artery. And I've already got a good strong pulse right there. So there's popliteal pulse. Now if we move to posterior tib, you could keep the patient in prone, but I'm going to go ahead and have her flip over because it's much easier to get the dorsal pedal in supine or even sitting. So let's just flip her over, and we're going to look for the posterior tib. So we're going to move just posterior to the malleolus. This one's hard to get. You're kind of in between the malleolus and the Achilles, closer to the malleolus. And apply, you have to go a little bit deeper to try to feel this one. And, oh, actually got one there. Okay, so here's posterior tib pulse. And just realize you may not get it here, and that doesn't mean that they've got arterial issues. Where you really should feel the pulse, though, is the dorsal pedal. So let's look at this foot here since it's closer to you. So we're going to go right in between first and second and come right on top of the foot. And again, if you push too hard, you're going to occlude it. I have found a lot of times, sometimes it's not exactly where it says it is. Anatomically, it may be a little bit different. If you just skim your fingers and then rest the weight of your hand, often, and I've already got it, she's got a good strong pulse. And here it is right here. If you have trouble find it, move around just a little bit and see. And again, be very light, because particularly with people who do have issues, you can very easily occlude it and then you're not going to feel it, okay? All right, now let's look at rubor of dependency and reactive hyperemia. So the patient's supine, we're gonna elevate the leg to about 60 degrees, and we want to observe the plantar surface of the foot for 1 minute. And what we're looking for is if there's no significant color change with elevation, that would be normal. If there's restricted flow, it's gonna go really pale with elevation. And then we're gonna have her hang it off the edge of the table, and we're gonna look for color changes. So we elevate her leg up to 60 degrees, and we're looking to see any changes in the foot. And again, look at what it was originally. So I'm kind of looking where she's got some pink here, and I'm looking to see if there's a change. Obviously here where she had pressure, see where we have, this is a good little non-blanchable pressure there where she had her heel resting. And again, we don't see any change here. I want to be careful where my hands are. If I'm holding the patient, I may actually occlude a few things and cause that, so I want to be careful about where my grip is. And we don't really see any changes. Toes are staying pink, everything looks good. Okay, so then we're going to ask her to go into sitting and hang the leg down. So come on up, and we're going to hang the leg down, and we're going to see if there's a difference in color here. And again, patients that have arterial issues, you will definitely see significant changes in the color. You're going to see it go really pale when it's been up in the air for a while, and more importantly, when it comes back down, you're going to see this hyperemia, this real change in redness as the foot goes back down. Again, with this person, we don't really see a lot of change. We see some tan lines here. You don't want to get confused with tan lines and changes in color, but don't really see any significant changes in that. So now, let's look at the little note here. If it's dark red, that's that rubor, or it takes greater than 30 seconds, then that's positive for arterial insufficiency. If the color return is immediate, then there may be some venous insufficiency, okay? All right, so let's look at venous filling time. So again, the patient is lying on her back, she's in supine, and we're gonna elevate one leg until the veins are empty. Now this one, we were just talking earlier amongst ourselves, it may be actually better sometimes to see this on your hand, because you may not just see real good changes in veins here. So let's do it on an arm. So come on up here. And let's hang your arm down so we can see your vein. Let's get the camera up here where you can see her veins here. And so now we see the veins are filling up and they're beginning to really stick out here. So once you're seeing the veins are full, now we're gonna elevate. We're gonna wait until, let's turn your hand where they can see your hands, where they can see your veins. I don't know, can you guys see that very well? Okay, so we wait until the veins are empty. Takes maybe 15 seconds, and then we're gonna hang back down again, and we're gonna see how fast the veins fill back up again. 2, and we're counting, 3, 4, okay, and she's already getting about full again a little after 5 seconds, okay? So let's look at interpretation. So we're looking at the time to refill. So if it's 5 to 15 seconds, it's normal, and that's about what we saw on her hand. And you guys do this on yourself. Do it, better yet, do it on some of your elderly family members. Try, if you can see that there's some, especially if you've got a family member that's got varicosities in their legs, this is really good to look at. It's interesting. And elevate and then hang down and measure some times here to see. So on this person, we had 5 seconds, so you'd record that. Greater than 15, you've got possible arterial disease. Less than 5 seconds, you probably have venous insufficiency. You'll really see that on someone with varicosities on their legs. You'll see those veins really protrude within just 1 or 2 seconds of hanging back down, okay? All right, capillary refill. Capillary refill, I'll do this on most of my patients. Come on over here. Let's hang down a little bit. Okay, so what we're gonna do is we're gonna apply pressure to the nail bed until it blanches, and then then we want to release quickly. So we see a nice big pink big toe there. So I'm going to apply pressure there and see there. So let's look on the nail bed and apply pressure, and we see until it returns. And this is a cold foot right now because it's freezing in this room. So these nail beds are already kind of pale. It's hard to tell on this foot with seeing the blanching at the nail bed. I like to do also just in a meaty area too to see that blanching, and sometimes I'll look in different to see how quickly they have that return. It should be just a few seconds from palpating and then release, and you should see the pink come back. Again, if it's a really cold room, you may have a little bit of a delay on that, but it still shouldn't be more than a second or two. So if we look at what normal is, normal refill is less than 3 seconds. And flip your page over, and we'll go to skin temperature after that. Okay, so let's look at skin temperature. You know, these days, we have all kinds of ways to measure skin temperature right now, and I think everybody looking at this has probably had your temperature taken recently. And so we have many monitors that don't even have to make contact, but we do have something here. Your hospital may or may not have one of these, but it's a quick way to get temperature. So we can put right on contact. It has a separator there, so we can just put it on there. Am I doing that right?
Punch it one more time.
There we go.
Yep.
Okay, and there's 83.1 skin temperature, okay? But I would bet you probably have one of those more modern devices now and you can do that. But what was the number there? I think it was 83.1. You can record that. And ABI, that's gonna be the next station. Okay, we ready? Okay, moving along, we'd be at station 3 now. So we're looking at ankle brachial index. And instead of going through all that here, there's a great video that you have on Blackboard, and I want you to watch that video. It does an excellent job explaining everything about it with patient positioning and how to perform the procedure. You want to make sure that after watching the video, and you can use your reference material to fill in here on your sheet. And as far as the numbers here, since we're not going to do it here, I'm going to go ahead and give you 2 numbers to fill in. I want you to put for the ankle systolic, the number that we got was 120. And then for the brachial, we got 130. So put those 2 numbers in and then do your calculation on your sheet. Now let's move down to station 4, which is edema measurements. So what we're gonna do, we're gonna measure edema measurements on the leg here, and you're gonna need to record your numbers here on the back here. And are we gonna do all of the columns, or we're just gonna do the one column?
Yeah, we'll just do the one column.
Let's do the one column. So you're going to record all those so that you'll have those on your sheet. And we'll go through how to do that. So let's look at, to save time, if you notice, it talks about going every 4 centimeters. And so patients in short sitting, you want to measure every 4 centimeters. And so it might be good that you're consistent, that you go ahead and tape down one of your tape measures, or you could mark the patient's leg, either way you want to do it. I've done it both ways. It depends on the patient. Sometimes you can't see your marks, or maybe there's some wounds or skin breakdown and you don't want to put marks on it, you just want to use the tape measure. A lot of companies will give you disposable, so just put it on and you can discard it after that. So let's start, we want to start at the medial malleolus. Let's talk about technique. So we're measuring in centimeters. You want to make sure that as you come around that you are not pulling too tight. You're basically taking out the slack, and make sure that you go circumferentially around, that you're not at an angle. Pay attention to what you're doing there. You want to be the same on each. We come around, and so the number at malleolus, as we're going to say, is exactly 22 centimeters. And I'm at 2 centimeters. So I'm going to go up 4 centimeters. So 22 is at the base here. We go up 4 centimeters, so we're going to go up to the 6. We're going to measure at the 6 in centimeters. Make sure we go around without pulling. Take out this, let me turn it where you can see it. See my number here. Some of you can see my number. And I am at 23. I'm going to go up 4 more centimeters, so now I'm going to be at the 10. Now you see some slack in this. Just make sure as you come up, you take the slack out and you're going to be at the right spot. So again, we're going to be right at the 10. Make sure you go straight around. Just taking out the slack, but don't pull tight. And the number now is 26, and that's at 10 centimeters. We're going to go up to 14. Make our way on up. Again, make sure that you come straight around. You start getting into the calf muscle and it gets tricky. So you want to make sure that you are even. And we're almost, if we're going to be precise here, it's actually 30.2. So 30.2 at 14. Let's go up to 18. right here. And again, we want to make sure that we carry it carefully straight around. Calf muscle starts to make it a little more complicated. And let's talk about that. You really care about the top of the tape measure. If you have a thicker tape measure, you may notice that the bottom is reacting to the change in shape of the calf. Focus on the top of the tape measure, that's what matters. Okay, so now we're at 34 at 18. We're gonna go up to 22. So you had 34 centimeters at 18, now at 22 centimeters. Again, I'm just taking out the slack. And we're up to exactly 38 centimeters at 22. Let's go up to 26, right here. Again, I'm careful to come right around. I'm focusing on the top of the tape measure because the bottom has a little bit of slack to it. And we're at 38.5 centimeters. And we'll do one more at 30. You want to make sure you get beyond the bulk of the gastrocs. You want to come up above that. So 30 at 30 centimeters, and the number is 36.3. So you notice as we got above the calf, the number began to go back down, and so we know we got past the bulk of the calf. So there's our measurements for that. Okay, so before we move on to the volumetric measurements, let's talk about those calculations, because I'm sure you guys are like, what? I got these numbers, they're not matching up. Well, first of all, I started at 2 centimeters and did every 4 increments. So if you want to just change those, it'll be 2, 6, 10. You saw how we did our numbers. And we stopped at, I believe it was 30. So you're just going to have the number of measurements that you had there. And then what you're going to do is square them. So you'll carry the squared number over here. You're going to add them up. And you're only going to use the ones that we have because we didn't do the whole leg, and that's fine. The sum of those squared numbers is down here, and then you divide that by 3.14, and then there's your answer. So that's how you get your calculations on this page, okay? All right, moving on to volumetric measurements. And as always, if you've got any questions on any of this, you have my contact information, and I'm more than happy to answer any questions that you might have on any of this, okay? So volumetric measurements. So here what we have, here's a looking at edema, and it's just another method to look at the reduction in edema in extremity. So obviously before you did any intervention, you're evaluating your patient, you would take this to get your baseline numbers. And periodically we retake our measurements. How often do we do it? It depends. Sometimes we do it before and after each intervention. So in one treatment we may measure before we do our intervention, whether it's wrapping or manual lymphatic drainage, whatever we're doing, and then measure them afterwards. Sometimes if the changes aren't as drastic, we may measure it every other treatment or once a week, depending on how often the patient's coming. So first of all, we want to fill our velometer with water. And what we did right before you guys were watching here is we filled this up to the point that a little bit of water spilled out, because you want to make sure it's completely filled and it needs to stop dripping. Once it stops dripping, you need to empty your measuring container so that it's going to get an accurate measurement. Okay, so here we are with that. So now we're going to ask the patient to put their arm down in the velometer, but first make sure they remove anything. She's got a ring on, so we need to remove that ring. If she had a lot of edema, she probably wouldn't have that ring on anyway. Wouldn't fit. So then we ask her to very slowly go down, and there's a pin in the velometer. If you see here, she's going to go down. Oh, wait, nope. What not to do? And that went into my shoe. So let's refill this. And you know what? That's real life. That happens. See, we have bloopers. So we're going to refill this until it drips. And then let it stop dripping again. Wait till it comes to a stop. Happens all the time. You're like, oh wait, I wanted to take that off, but I wasn't quite ready. You might have to go to the bathroom now. All right, once it stops dripping, then we're going to empty that back out. And now, before she puts her hand in, what I was explaining is you want to make sure that you tell the patient that in between the web space of the second and third digit, she's going to catch that, and she's going to stay there until it stops dripping again. So go ahead and proceed nice and slowly. Stay right there. Don't move, just keep your pressure resting on that. We want to wait until it stops, completely stops. Still dripping. Okay, so after it stops, we remove, and she'll dry the extremity. And then we'll pour, the water is in here, we'll pour it into the graduated cylinder. You can get the results. And we'll record that amount right there. You don't want to be holding this because you don't know that you're level. You would need to be on a level surface to get that number there. And the number that we have here is 454. So 454 would be our measurement for that one, okay? Wet paper here. Okay, and that's the amount of displaced water. All right, moving on to station 5. Okay, so here's our last station. This is wound measurements. Now for me, I normally just use a disposable ruler to get my measurements. So we're going to show a few different ways. I think all of these are great, and if you have the availability to do these different ones, see which ones work the best for you. But what we're going to look at today is to see how accurate these different ways are compared. So that's why you've got your sheet. And we're going to measure 3 of the 4. We're not going to do the volume one. It's very, very rarely used, and so let's just skip that one. But the first one is when you're measuring a wound, say this sacral ulcer here, you're going to measure the greatest length by the greatest width. Now you have to stay vertical. You can't cheat. Let's say the wound were diagonally placed. You can't decide to go on a diagonal. If you're going to say length by width, it's got to be anatomical, so it needs to be vertical. If you do go on a diagonal, you need to say that in your note where you took it, from 2 o'clock to 7 o'clock. So for this test that we're doing here with our lab, let's stay vertical. We're going to say the greatest length, and what I do is I just come along the wound and I wait until I see where I think I see the biggest number. And so I'm seeing right here, it's going to be 6.3 centimeters is what I'm seeing right there. I get right on it, 6.3 centimeters. And so now we're going to go by the greatest width. And that width is going to be, looks like about right where I was, right there. And it looks like it's going to be right at 4.5 centimeters is what I'm getting there, 4.5 centimeters. So put those 2 numbers down. All right, now for your second line, you use those numbers and you calculate by looking at pi divided by 4, which is the area of an ellipse. And there's your second number there, so calculate that. And we're going to see how that compares to doing it with the grid. So now we're going to use a transparency, put it over the wound, and you really want to get it flush with the wound. It needs to not move around. You're not going to get a valid measurement. So what we're going to do is we're going to trace the wound. Okay, so we're going to draw here. Make sure it's good and flush. Can't move around. Got my tongue sticking out. I'm glad you can't see that. Okay, let's move over here. We'll move over to the grid. So now we're looking at the number of whole grids and partial grids. So if we count up the number of whole grids that are included, got 1, I'm going to count that one, 2, 3, 4, 5, that's not completely whole, this one is, 6, 7, 8, 9, 10, 11. Now we've got, this is definitely almost a whole one here. And then we've got a half and a half, so we'll make that a whole one. So 2 halves there. I'm going to count this one, that's pretty full too. So we're up to 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Here's a bunch of, that's less than fourth, so we'll say 15 there, 1, 2, 3, 4. It's a little less than half. It's a little more than half. So we'll say, this looks like a whole, we'll say 16 and 2 halves, 16 and a half, 17 and a half. I'm gonna say 17 and a half, okay? All right. Okay, so that's the end of our patient assessment lab, and you guys should just complete your calculations and finish that. You can submit it per the instructions that you've been given. And just remember, you know, the main reason that I wanted you to see all this is seeing it is so much more practical than reading about it. And more importantly, doing it is the best way. And so, you know, we're making do right now. The main thing I really want is that you just took the time to look at it and make sure that each of the assessments makes sense to you. And you can kind of look and see the ones that were easier to do than others. And, you know, I'm not so worried about all the numbers as so much as I am of you watching it and thinking about the procedures that you would use when you're assessing your patients and which ones are most appropriate for the different diagnoses that you have. Okay? Thanks.